Yeah, with this, I invite Dr. Suma Ganesh, my dear friend, who has kindly consented to participate in this IC, and she will be talking on surgical management of Duane's case-based approach. So, Dr. Suma is Director of Pediatric Ophthalmology and Strabismus at Shroff Charity Eye Hospital, Delhi. She has done fellowship in Pediatric Ophthalmology and Strabismus at Manhattan Eye and Ear Hospital. She is awarded SD Athavale Award for Best Paper of Squint in AIOS in 2003 and has received the prestigious ACOIN Award for her work in strabismus in 2012. Has huge number of publication, 111 to be in fact to her credit, and is currently working on childless blindness project with Orbis, Seva and Perkins International. And she is a very good teacher. So, Suma, your topic.
Thank you, Dr. Shubhangi ma'am, for the invitation, and nice to be part of this IC. And also thank you, IAIOS, for giving us this opportunity. I think my topic has mostly been covered by ma'am, but I'll just go for surgical management of Duane's retraction, a case-based approach.
12 minutes. Make it 12 minutes. Each talk is 12 minutes.
Yeah, that's what even I thought for your talk it was less.
Acha, they hadn't put a what, 12
No,
minutes?
I think it was
Okay,
10,
yeah.
So this nicely madam has covered, Dr. Shubhangi has nicely covered. It is basically the Duane syndrome is an absent or partially developed abducens nucleus and nerve. So basically most of the problems are with the lateral rectus. This has been proved by a lot all the time, and that's why we need to, whatever tackling we have to do to the lateral rectus. The branches of the oculomotor nerve are redirected to the lateral rectus muscle. So now it comes under the terminology of CCDS. So the management, basically there is an abnormal head position, abduction deficit, there could be an adduction deficit. Then we have to see the amount of retraction, if there's an upshoot or a downshoot, primary position, what is the deviation, and unilateral and bilateral and fusion. So this means because basically now if you have to go for a publication, so we need to say how to say that our results have become better. So we need to grade our globe retraction so that we can say that it has improved. So this is how we grade that. We take it from, we make the eye adducted position in the normal eye, and then we measure it along the limbus, and we see this is the 12 millimeter and this is 12 millimeter, and see here in this case it is smaller, that's 9 millimeter. So you take it, compare it with the normal eye in the position, and we can see here also it is grade 2 globe retraction, and then you have the pumpkin sign or the grade 3 globe retraction of 73%. So this is how you grade it. It is given in a publication by which is published in JAPOS by Dr. Shailaja Tibrewal et al. Same way they have also graded the upshoot. So this is all for publications. Basically it's a line drawn from the pupillary center of the normal eye, and when we do the surgeries we want to know whether the upshoot has been corrected or not. So this is how we plan. We say that the line between the drawn from the pupillary center of the normal eye, and we say how much is it between the pupillary center and pupillary margin, or between the pupillary margin and limbus, and or the cornea disappears below the lid. That is grade 4 or the pumpkin sign. So we have a case here of a 24-year-old male not able to move the eye. So this patient could not move the eye. So you can see that there is severe globe retraction, and this is a pumpkin sign, and also there is a grade 4 upshoot. So now in this case we have to tackle the abnormal head posture, the deviation, and also, so if you see here the deviation is around exotropia of around 20 prisms, much less than expected. Then right hypertropia, which was around 20 prisms, and we found that there was a phase turn to left side of 110 degrees, grade 4 upshoot on adduction, and then we also found severe globe retraction. So when we consider all these aspects, that is how we come to the surgical management. So now we know that it's a type 3 Duane's. Now we have to see, we have to correct the head posture, we have to correct the exotropia, we have to correct the head hypertropia, and also the upshoot and downshoot. So there was in the MRI suggestive of absent abducent nerve nucleus. I just wanted to check on the inferior rectus. That's why I got the MRI done, because I wanted to see whether, because there was severe globe retraction and vertical deviation, I just wanted to check whether there was an inferior rectus present or not. It was present, but there was hypoplasia though I didn't know, we didn't get it so much on the in the when we're doing the surgery. So this is a globe retraction which we see on adduction. Although my videos are getting turned, I don't know why.
Slowly.
The severe globe retraction. So this sign has been said by the Eisenberg and Urus. They have documented this sign that there is drooping of the upper lid along with elevation of the lower lid in about 52% cases of Duane's. Just a sign, and I felt because this patient of had this, so I thought I'll take a video of this. So this has been published. So so we thought like, okay, now we have a dexotropia type 3 DRS with hypertropia with combined mechanical and innervational upshoot. This we got an FDT which is tied for a medial rectus, lateral rectus, and superior rectus. And in this case, we planned a lateral rectus recession with a Y split. So for a 20, we all know that the exotropia we have to correct. It is you have to do large amount of lateral rectus recessions because it is 1 millimeter for one diopter. So we did a lateral rectus Y split. I use the small hook for the splitting of the muscle, and then we have to split it. So I think the video has already been shown of the Y split. So the most important thing in the Y split is that for recessions, and also that we have to keep them around 20 millimeter apart. So that is what we say that. So if you measure it, the 10 millimeter is a point at both the edges of the 10 millimeter where you have disinserted it. You go down there and mark the. Now I'll just show you to you. You mark there. So go down here and you mark. See here. This is 10 millimeter. And so when you take your full, that means it is 20 millimeter apart because the 5 millimeter of the muscle of each split. So this is what it mentioned in Rosenbaum, that you have the muscle which is 20 millimeter apart, and then you suture the conjunctiva. So post-operatively, he is very good. He had no face turn, upshoot, and globe retraction also was reduced. So if you have to have a publication, because we send this for publication, so you need to measure, tell them how much your globe retraction or your upshoot has reduced. So that's why that measuring it is important. Case 2, also a 6-year-old child with an abnormal head posture and squinting of eyes since the age of 1 year. So we found an extorsion on the fundus in the left eye. So this was again an exotropia of 18 prism diopters. She had a left hypertropia of 6 prism diopters, but there was very minimal globe retraction. Left, there was an upshoot which was on adduction, but this upshoot also we can, if you grade it, it's around only grade 1. So now how do you, how, and when we found, when you have the video, we found that it was a gradual shifting of the eye. So it was a left hypertropia with only 6 prism diopters, and which increased on when you've seen in the, if you see in the dextro version, you find that it has increased. So the measurements also of your exotropia has increased. So this fitted into our innervational upshoot. So what we find, there are 2 vertical movements in DRS. One is a mechanical, where it is abrupt up and down movement, and you have a gradual elevation and depression, which is innervational. They have a vertical deviation in primary position. So this is how we differentiate from a, so suppose if you have a vertical deviation in primary position, mostly we find that these are the cases which is the innervational type. So Mohan et al. Have found that the mechanical type to be more common, but this was a case where we had a innervational upshoot, and that is why I presented it, where we have done an inferior oblique myectomy has been described by Avadin, but for the mimicking the inferior oblique overaction. But in this case, I did a recession. I don't do myectomies. So I did a recession of 3:2, the Park's method, and a recession of the lateral rectus of 16 millimeter, and which gave me a good result. So this is how we plan whether we have to do an inferior oblique or whether we have to do a so then this is the other case. Again, these are all DRS with vertical deviations. So that is why it is so important to measure in all gazes, because it gives us a clue what we are dealing with. It is not only important in primary position. So we have here we have a hypertropia here of 40 prisms, exotropia of 25 prisms, and this we found that the hypertropia increased in the ipsilateral position. So we suspected a ipsilateral superior rectus contracture, and that's exactly what we found in FDT when we took up the patient, that there was an ipsilateral contracture, and we operated the patient with a, but still there was a residual of around left hypertropia of 14 prisms. Patient was doing well because it was under local, so we operated only one eye. So we did an exotropia LR recession with a superior rectus recession and a Y split because of the upshoot. The patient is doing fine. not come back for a resurgery, but may come back later for a resurgery because there is still small amount of left hypertropia. So this is a 25-year-old male with an inward deviation of left eye since childhood. So there is a turning of the face while reading is the complaint. So she was 25 esotropia for distance, and for near it was 20. There is mild globe retraction. So now your and decrease in palpable aperture left eye on in adduction. But if you see, it is very mild cases. So now these are the cases when you have mild but with a -5 adduction deficit, where you could try a superior rectus transposition. So we have to understand the cases. So we do not do superior rectus transposition in all cases. You may land up with more problems then. So, you do it in such selected cases where you have minimal globe retraction. So, superior rectus transposition, when you combine with medial rectus recession for Duane syndrome, so it will correct an esotropia up to more than, if it is more than 15 prism diopters, you need to do a superior rectus transposition and a medial rectus recession. But if it is less than 15, you can get away by doing just a superior rectus transposition. And it has not, in this paper at least, it has showed that there is no torsional diplopia. And in the few cases which I have done, there has been no vertical deviation or no torsional, but it depends on the case selection. So I think she has already shown the video of a superior rectus transposition, just a small video. And so in this case, we did an SRT with 4 millimeter recession. So these, how much to do and all is given in. So I've done a fornix incision. So fornix incisions are when you have to do a superior rectus transposition is better. And once you isolated the superior rectus, then you transpose it to the so whenever you are transposing any muscle, you need to dissect the muscle a lot. That's what we need to, and because we need to dissect the muscle up to around 10 to 12 millimeter behind. Otherwise, the muscle will not, you'll not be able to shift the muscle, and even your effect of the muscle won't come. If you don't cut it, you don't cut up to around 10 to 12 millimeter, at least the check ligaments and the intermuscular septum, and then you shift the to. Since I had also a medial rectus recession, so this I have shifted it to the lateral rectus. So this is superior rectus transposition of the. So you can see the muscle easily is coming to there. That is because you have dissected so far off. Otherwise, you find you're struggling pulling the muscle towards the lateral rectus. So this is the superior rectus transposition of the muscle. And then so you take it around 8 millimeters from the spiral talus. Okay. So 1 minute is there. So these are the post-op pics of the patient. Now you have another patient. So this is again a small esotropia with small face turn with minimal globe retraction. So in this case, I did only a SRT because 10 millimeter, just 10 esotropia, and the patient wanted that his abduction improve slightly, and he was concerned about. So in this case, we did only a small SRT. We did SRT, superior rectus transposition, and it worked. So it is all on patient selection and the management strategy. So I have not done an inferior rectus transposition. I was tempted once, but I have not done it yet. Because they say it can be advantageous in patients with an A pattern, with a V pattern if you do an IRT, and it is more SRT can be more advantageous in patients with an A pattern. But I have not done for a case of IRT for any case. So this is a simple case of 25 prism where you do a medial rectus recession, and this is an exoduans which ma'am has nicely covered, where it is 40 prisms for distance and near, and for distance, and you do a lateral rectus recession with a pie split. So in these cases where you have so in large XL exo-DRS with downshoot, this cases I did what I did was basically a large recessions of lateral rectus. So I feel that more than, because not a severe upshoot and downshoot was there, so I did a large recession of the, and this is orthotropia, where again I did a differential, where again like as ma'am said that it is our LR recession with a MR recession of this. Now the last slide, which is a type 4 synergistic divergence. I would do only lateral periostal fixation for such cases. I would not do for other cases of exo-DRS. This has been my learning, and I prefer my lateral periostal fixation to third nerve palsy, and also to cases of like the synergistic divergence. So I'm not sure, has Dr. Barsha pointed, I'm not sure whether it will be effective when there is an upshoot and a downshoot. Though I think logically it should have an effect, but yes. I'm not very sure. So because the abnormal innervation, but it should work, I think.
I think
I'm not done, so I don't know. So I prefer only in synergistic divergence in Duane's and in cases of third nerve palsy.
Thank you, Dr. Suma, for, as usual, a talk which teaches you the basics and beautifully covered it. Anyone, please, any questions on this topic so that then we can go on to the last talk? Yes.
More than you combine it with a medial rectus recession. So, what's your long-term experience in SRTs? Because I have seen they tend to have a little overcorrection with time. Do you have that experience? So, I'm a little hesitant in doing that MR recession, especially in smaller children, because I've seen over the time they have a tendency to go for a little exo. So, I just want to know how do you titrate? And I also want to know when do you do a Foster's augmentation and the technique of augmentation, because there are different techniques in which some people just tie the muscle together. There are some techniques in which they advise you to do a scleral bite also. So what's your experience and when do you recommend this?
So, what I would say is that SRT, what you're saying is that if you do an SRT combination with a medial rectus recession, you have found an overcorrection.
Yeah, but I think the ones, I think I did a Foster's augmentation also
Yeah,
with that, but the angles were larger, of course.
Yeah.
It was about 40. And but
See,
the MR
whenever there
recession
is
was
a very
small.
large angle, no, like see in these cases, when suppose if it is like 30, well, mostly 30, 35, they don't come up to very large angles in ESO. At least I've not seen very large DRS
Yes.
deviation. In maximum, I think I've seen is 35 or 40. In those cases, mostly I prefer to do a bimedial recession. Frankly speaking, I don't do an SRT unless it is one eye. And like when if I, because SRT, I leave it very few cases where where I find that the deviation is less,
Abductions, huh.
and there is and there is good adduction, and you have only an abduction deficit, and the globe retraction, upshoot and all not there at all. So actually those are very rare cases, like
So the no
what,
retraction, no upshoot.
yeah, then those are very rare cases. In those cases I prefer, like if SRT I've done is mainly for 2025 I have not found overcorrection, because then in those cases medial rectus I've only done 4 millimeters.
do a less.
Less
Why I
amount
said
of-
is because there are some papers which compare it with LR palsy. Like
Uh-huh,
they
yeah,
say that in LR palsy you hardly get an overcorrection, but in DRS, unless you're careful, you can get an overcorrection when you combine it with an MR recession.
So
I
the
just wanted
MI
to-
recession only has to be as much as to reduce the contraction,
I've
the
started
FDT,
I've started
release the
reducing to
FDT.
hardly 3 mm, maybe
Huh,
very
3.5 is
and
also
I
good
sometimes
enough.
find that even that produces some adduction
Yes,
deficit.
yes.
So I'm like, I'm just wondering whether I should
That is
do it at
because
all.
that is because we are not doing away with LR abnormal innervation. LR abnormal innervation continues even after Y split or recession or whatever.
But alone SRT, in 2 of my cases didn't work. So, this boy had very minimal, so 10 prisms, so that's why it worked. But otherwise, I found that if like even a patient of around 15 to 20, I thought let me do 15 to 20 it was. I said only do an SRT because the tight contracture of the medial rectus, the abduction did not improve at all. I had
Actually,
to go back
only-
and do a 3
yeah.
millimeter MRSS.
Only if the FDT
Yeah,
is
so
negative,
Only if the FDT is negative,
then
it's like it
maybe
works.
SRT alone would
And
help.
sometimes you give this midway FDTs, isn't it?
Yeah, yeah.
Right? So then also I do a small MR recession because you really don't know whether it's going to work or not. Thank you.
Yeah, and the Foster suture you were saying, normally I take the Foster suture attached to the sclera, but some people attach muscle to muscle also. But to me, if you attach it to sclera, it would have a better effect.
But does it produce torsion? Because there are some studies which says that with torsion has been a concern when you attach it to sclera rather than when you just put.
I have not
I have not
found any
experienced it.
torsion.